Well, thank you, everyone. I'm excited to be here. I love to meet with young people, and I love that you guys are here. And I know the big thing for you is to meet each other. So I'm going to keep my comments brief, and I really want to hear from you all and hear your comments and hear your questions. So, one technical issue. Sorry.
We like to feature Rhett in most of our stuff, but just not today.
Okay, now, and then do I push like F4 or something to get the screen, or F8? What do I do? B?
Letter B.
The letter B. Got it. Look at that. Fancy pants. Okay. Well, again, I'm Dr. Koestner. I'm very excited to be here, and I'm talking about FEMM. FEMM stands for Fertility Education and Medical Management. So I don't get to talk to students a lot. I often am talking to medical students, residents, and doctors. So this is an exciting opportunity to talk to you all. Okay, so what we're going to start with is just reproductive hormones. What's happening inside your body, and why is it that I'm here talking to you about this at a Love and Fidelity conference, right? Because I think what you guys have experienced probably in the healthcare world is that most of the time we don't take a very evidence-based approach to women's health care, and a lot of women aren't being heard, and a lot of people aren't being cared for in the most evidence-based way possible. So that's what our mission is to do for women and for couples. So we're going to talk about women mostly, but we're going to talk about men too, because you guys have to know you're an important part of this puzzle. So for women, each cycle, you guys can see this. I just want to show you this kind of basic complex workup of hormones here. I don't know if there's a little, what do you call it, a little pointer on here. Maybe not, but you can see that in the upper right-hand corner, that there's a lot of happening in a woman's cycle, right? There's different hormones happening, and they go up and they go down. And so women have this emotional difference among men where we're kind of feeling different from day to day to day. And in men, you have the same FSH, but you don't have all of the ups and downs. Your hormones stay pretty consistent from day to day to day. And so emotionally, men tend to be a little bit more consistent in their emotions from day to day to day, and that's built into our bodies physiologically. Then the other piece that's interesting is our fertility throughout our lifetime. Do I have to stay by this microphone? This is going to be really hard for me. I can do it. He says to do it. Okay. So men start their fertility around puberty at between 10 and 14, and then their fertility increases, and then it goes really throughout their lifetime. You see that top line back there? And then for women, our fertility starts again around 10 or 14, but then we have these ups and downs with pregnancy, breastfeeding, and our fertility is gone by the time we're in our mid-40s, late 40s. Okay, so what happens here? Hormones from the brain signal the ovaries to develop an egg and produce the hormones estrogen and progesterone. So it's a very complex system that involves the brain, the adrenals, and the ovaries. And many times when you go to a doctor, they are talking to you about whatever system you're presenting them. For example, you go to the doctor for acne, and they're only thinking about your skin. But what we really want to train doctors and students to do is to think about the fact that that acne could be coming from a problem in the brain, the adrenals, or the ovaries. And so getting them to think about the whole axis, the whole hypothalamic pituitary adrenal axis. Okay, so in order for this whole system to work, each hormone must get to a certain level to stimulate the next hormone. Okay, and so we're going to walk through this cycle and what's actually happening. Okay, so I'm going to just show you this. Okay, so in a woman's body, we start with FSH. So FSH comes from the brain, pituitary gland, and that has to get to a certain level to stimulate the next hormone, which is called estrogen. Estrogen now has to go on a certain slope. Estrogen can't just be all of a sudden there, can't be there in low levels. It has to be there, and it has to be going up very slightly in order to get the next hormone from the brain, which is called LH. So FSH, estrogen, LH, okay? And that LH has to trigger, and it's actually a plateau that happens. It's not just a spike, but it's about 36 hours, and that hormone has to be present in order for the egg to rupture out of the ovary and cause ovulation. And then in order for the next piece, the progesterone, that little gray area, we need to have enough, we need to have the ovulation before the progesterone can reach a significant level. So we can't just say to women, oh, you're not ovulating or cycling. Here, just have this progesterone, right? And so that's not a good way to treat women. And again, each hormone must reach a significant level in order for ovulation to occur. Now, I want to show you this slide because it really helps us understand the importance of estrogen and the importance of progesterone. And they do kind of two different things. Kind of think of them as the opposites, right? The estrogen does the one side of things, kind of increases blood flow and helps with the different things in the mood, and then the progesterone does the opposite. And so we need a good balance of both in order to have a healthy cycle. Okay, ovulation is the key sign of health. For women, you guys all maybe have downloaded some sort of period tracker app on your phone. This is kind of the most highly downloaded app right now for women, is some sort of period tracker. And that's what we're taught to think about, is when is your period? Is it regular? Is it not regular? And that we all have our own pattern, and some people are regular, some people are irregular, and that's normal. And I'm here to tell you that's not true. That women should have regular cycles. And if they don't, there's something wrong, and we need to diagnose and treat what that is. Does that make sense? So what we're looking for, though, is more than just the bleeding. We're looking for the ovulation. We're looking for a woman that has bleeding, followed by what we call a follicular phase that leads to ovulation, and then a nice long luteal phase that's 11 to 18 days, and then their next period. And if that's not happening, then we know there's something going on that we need to diagnose and treat. Okay, so FEMM has developed an app, of course, because we have to, because people love apps, right? The FEMM app is great, like all the others. It's a period tracker, but it does a little bit more than period tracking. It actually interprets data that you put in for you. So it has different biomarkers that women have that they notice in their cycle. For example, maybe LH testing that some people use with a monitor. There's like hormone monitors. There's cervical mucus that women can use to put into the app. There's temperature women can put into the app. There's signs and symptoms. Maybe women have mood changes. Maybe they have acne, different things. So you can put all of this data into one place, and the app actually will give you some feedback, and it says, hey, this is normal, this is healthy, this is not normal, okay? So this is kind of what the app looks like. I use it a lot in clinical practice. So I did 10 years of full scope family medicine and OB. And I found that women were downloading apps anyway, but a lot of times it was just about their period. So what I was trying to get them to do was have an easy app that's free that they can download and really learn a little bit more about their body and use that to track their health. Now, from my perspective as a family physician doing OB, I really was interested in people's health. What they were interested in, especially when they were younger, was not getting pregnant unplanned or getting pregnant. Maybe they were married and they wanted to have children and they couldn't get pregnant. And so that's the other piece of, that was their piece. For me as a doctor, I was really looking for their health. How can I make sure that they stay healthy and diagnose and treat? So this app is really great for that purpose. Okay, so I want to show you guys these charts. This is what a woman's cycle might look like when she puts the information into the app. This probably doesn't mean a whole lot to you guys at this point. Let me see if this little... Okay, I'm going to have to walk over there, I think. Is that okay? Is that not going to work? He's like, a point. It's okay. It's okay. I'll just say, look at the top one. Okay, so... Is there a pointer on here? Show me. Is it the middle one?
No, it doesn't. My apologies.
No, it's okay.
We'll
It's all
cut that
good.
out.
It's all good. Okay. Oh, it's okay. Oh, look at that fancy thing. Oh, look at this. Okay, thank you. Okay, so what I want you to see here is that these are 5 women's cycles, and they're all normal length, right? What we're looking for is anything from 24 to 36 days for a woman's cycle that's the normal length based on the reproductive physiology endocrinology data, okay? And what we're looking for is, Are they ovulating? Yes, all these cycles, the woman is ovulating and she has a normal cycle length, but you can see different things happening. So it's not just ovulation, it's also what else is happening in the cycle. You can see on this one right here, there's some bleeding that happens around the time of what we call peak or ovulation. And then right here, there's bleeding throughout the cycle that's happening. And so that means that something's not right with the hormones, even though she's ovulating and even though there's a normal cycle length. So I just told you that ovulation was the key, and it is, but there's other things that we want to look out for as well. Okay. So that comes to how do we use these protocols to kind of diagnose and treat. I just accidentally did that. Okay. So 1 in 3 women are on the pill for non-contraceptive reasons, right? So the reasons that women use the oral contraceptive pill or combined oral contraceptive pill are a couple different reasons, well, many reasons. And these are evidence-based guidelines. Doctors, in their defense, are following what they know to be the right way to practice medicine. So we're told as doctors, if a woman has an irregular cycle, you need to put her on the pill to help regulate her cycle. We're also told if she has pain, bleeding disorders, or cramping, that the pill could help lessen the pain and cramping and regulate the bleeding. And that's true, it will. PMS, maybe they have premenstrual syndrome where they get mood changes with their cycle. And the doctors will often now recommend to put them on the pill to kind of regulate their hormones. And they maybe get mood swings, maybe they have acne. Maybe they're put on the pill for acne purposes. Maybe they're put on because they're anemic and they bleed too heavily, and so now they need the pill for that purpose. And maybe they have endometriosis, which is where the inside lining of the uterus grows outside of the uterus, so maybe they're on the pill for that. Or maybe they have PCOS. This is the evidence-based guideline for PCOS. And so these are many reasons why I use this prescribing in the beginning of when I started practicing. But as you guys know or have experienced yourself, there's many side effects to these medications, which include infertility, bone and mineral loss, strokes, blood clots, cancer, breast and cervical, and obviously the risk goes up the longer the person uses these methods. In particular, it's really high risk if we start them in their teenage years. So if the health problem is not identified in treating, the underlying condition often gets worse over time. So what we're doing is going around and helping in different medical schools, residency programs, different hospitals all over the country and all over the world, trying to teach them about these RHRI medical protocols. RHRI stands for Reproductive Health Research Institute. And what we're doing is most doctors do this part. They do the history, they do the exam, and they do the lab testing, right? And then that's kind of what you experience when you go to the doctor. What we're asking physicians or PAs or nurse practitioners, midwives that are taking care of women is we say, okay, do that part, don't forget that piece, but also add in the chart. Have them download the app and get started charting, or use a different app that they like to use that helps actually track ovulation. And then do what we call a basic hormonal profile, and then use an ultrasound. So kind of normal medical stuff, but just getting a little bit more information, okay? So what is normal in a woman's cycle is that the cycle length we said is 24 to 36 days. So these are things I want you thinking about when you're thinking about your own cycle. And then the luteal phase length should be 9 to 18 days. So after ovulation, there should be 9 to 18 days in that luteal phase if that's a normal ovulatory menstrual cycle. So when things are outside of that range, that's when we're starting to do an evaluation and figure out what's happening with that woman. This is the lab test that we do. So in addition, it's kind of the full set of labs that we do. This one at the bottom is called an oral glucose tolerance test with insulin levels. So one of the most common things we're seeing right now is insulin resistance. You guys know what our diets are like in this country, and the experience that we're having is that a lot of patients are eating a lot of sugar, and so they're developing a lot of insulin resistance. Okay, I just want to show you an example for your group of what women are experiencing when they go to the doctor and how we're trying to do it a little bit differently. So this is a protocol that we use for acne. We have a whole slew of protocols for different things, but let's say you're struggling with acne. Then what happens is we do a complete physical exam. And then we do the lab tests. And we look at, okay, let's look at these specific lab tests we do here. And then we kind of say, all right, which one's abnormal? And then we have protocols based on all of those. So let's say her DHEAS is high, which is a common cause of acne. And then we go to that protocol and say, well, why is that hormone high and what do we need to look for that? Obviously, if it's not acne, we look at all the other things too. So we're not missing other medical diagnoses, but we're, instead of saying, here's acne, here's some acne medicine, we're saying, well, what's actually causing your acne? Let's treat that underlying thing. And many times that improves. Okay, what I want to show you is a different approach. So this is women's chart on the right side, and then these are the hormone levels. The primary disturbance is here, and that tells you exactly what's causing the hormone problem, and then the condition that's associated with it. And what I want to show you is that it's really important to track with some sort of system, an app or some sort of charting system, fertility awareness-based system, that doesn't just look at the chart only. A lot of times we're told, oh, if you just chart your cycles, then we can see everything that's happening. And I want to show you that that's really not true. So although I'm promoting an app and charting and how important that is for your health, I want to show you that just by charting, for example, these charts look very similar. A lot of dryness with a little bit of bleeding and a cycle. And then what's happening is the hormones are all kind of doing the same thing. The GnRH is low, FSH is low, LH is low. But if we go to the primary disturbance, this person has low leptin levels and they have anorexia nervosa. And this person has cortisol elevation, which is your stress hormone from your adrenal gland, and that's called hypothalamic amenorrhea. And so if we don't get to the root cause and we just use the chart, then we can get into trouble as well. So that's the basics of the charting system and how it works for a woman's cycle.